Welcome to the first lockdown learning session, GP trainee teaching. Look at it as like a national VTS. I know in a lot of areas that training is not happening in the same way, in that a lot of people aren't getting the educational sessions and VTS is cancelled. Some deaneries are starting to do some remote teaching, and that's fantastic. But I wanted to do something that is open to anyone from any deanery in the UK, just so that you don't stop throughout all of these additional pressures. You don't stop the learning, because at some time you're still going to have to do your exams and think about your life after CCT. So that's the purpose behind it. It's free for anyone to join. So if you find it helpful, do share it with other people in your VTS for next time. So let me just introduce you to myself and get you to tell me a little bit about yourself. I'm going to tell you about what we're going to cover in this session. So my name is Dr. Mohibur Rahman. I'm a portfolio GP. I have various clinical roles, and then I also have my main role is the medical director of eMedica, is in medical education. So I teach up and down the country. I'm an examiner for the GMC, for Liverpool Medical School. I write for the prescribing safety assessment, but I still, I'm a partner in a practice, and I still see patients. So I was in clinic yesterday. Some of you might have seen in the Facebook group, it's my homemade PPE. We had ordered full face visors, but they didn't arrive. So if you can see, this is my wife's sleeping mask, and it's just a piece of laminating pouch. I ran through a laminator, and I've used the straps of this to hold it in place, just to give me something. And I have managed to get a proper visor now from actually a dental colleague. I'm still waiting for the delivery to arrive. So that's me. Want to get to know a little bit about you guys, and that's also going to give me an opportunity to show you how to use this webinar software. Some of you might be using this software for the first time. So the first thing is, in the chat, just tell me where you're training, which VTS scheme, and if you're not in training, where are you working at the moment? So particularly interested to know which different schemes people are joining us from around the country. So just share that with me, and let me have a look in the chat. If it looks like I'm looking away, it's because I've got two monitors here. I'm just looking at the chat, which is in the other monitor. Okay. So we've got someone ST3 in Northern Ireland. We've got someone in Chester, North Liverpool, Durham and Tees Valley, Derby, Leeds, Worcestershire, Bridgend, Borada. I trained in Neathport Talbot, just up the road from you. West Midlands, Pennine, Windsor, Ipswich, Portsmouth, Epsom, Barnet, Gwent. Fantastic, all over. Okay, so that's how the chat function works, right? The next function I want to show you is the poll function. So I'm just going to launch a poll, okay? And I just want you to select your answer, all right, in the poll. So all I want to know is, you're just going to select A, B, C, D, and so on, okay? So I just launched the poll now. Just give me 30 seconds. And I just want to know, basically, are you ST1, ST2? And this way you get to see what the poll looks like. Okay, so here we are. Start the poll, okay? Now you should see in the poll section, next to the chat, there's a poll section. And it should allow you to click now, A if you're ST1, B if you're ST2, C if you're ST3, D if you're not yet in training, E if you're already a qualified GP. We might have some trainers that have decided to join, just to see what kind of things going on here. Okay, so I'd be very interested to see that. I'll just give you a few seconds, and then we'll stop that. But this just gives me an opportunity, because we're going to go through some AKT style questions, but then we're also going to do a couple of sort of scenarios that you might either see in clinic or that you might see in CSA. And so it's useful for me to know, first of all, the level of people in terms of where they are in their training, so I can tailor it to you. And then the other thing is to also just for you to get familiar with this software. Right, so I'll stop the polling there. Okay, and right, I'll close the poll there. So that's really interesting. About a third of you are ST3, about 29% ST2, 23% ST1, and then about 12% logging in early. And we've got just a few people, a handful of people, about 1% that are already qualified. You might be trainers, or you might just be interested in an update. So that's fantastic. But that's how that works. So just to recap, you'll see that in the format of this webinar, we're going to go through in the next 55 minutes we've got left, an hour in total. I'm going to teach on 3 different topics. It's going to be interactive, so I'm going to ask you some questions. We're going to do some cases together. You can get involved. And after each question or case or topic, I'll do a rapid review of the current guidelines, and then we'll be able to discuss things. So there's 3 things that you're going to see. You've already seen how to use the chat, and you've already seen how to use the polls to answer questions. So use the chat for comments, or I might ask you a question for you to answer me. That's what you're going to use the chat. If you've got a question that you'd like me to answer, and I'm going to take questions at the end, okay, please use the Q&A, not the chat. And that's because there's a lot of doctors on today. Okay, we had 900 and something doctors register. I'm pretty sure not everyone might have actually logged in, but we've got a lot of people on. So the chat often moves very quickly. It's very difficult to scroll through. But the Q&A, they come to me in the order that you've asked them. And so I'll be able to go through them in the order at the end, okay? And then just like I used the poll there, I'm going to show you some questions. We'll use the poll for that. So that's how it's going to work. And we're going to go straight into it. We're going to look at three things. So the main session, we're going to look at screening and assessment tools in general practice. Then we're going to look at pain management, including cancer pain management. And I'm going to do a very brief overview of the different GP careers after you finish training. And then over the course of, because we're planning to do these every week or every other week until the lockdown is lifted. That's why it's called lockdown learning. We'll go into a bit more detail into the different career options. Today, I'm just going to touch on what do the job roles mean, especially some of you early in training, ST1s and ST2s. You might not have a clear understanding of the difference between a partner, a salaried, locum, and a portfolio GP. So I'm just going to touch on that. We're going to explore those in more detail over the several weeks and months, okay? And then the Q&A will be at the end, okay? So we're going to start by looking at three different screening and assessment type tools. Well, actually, three different areas where we might use screening or assessment tools. We're going to look at more than three tools. So we're going to start by looking at depression, then we're going to look at dementia, and then we're going to look at falls. So if we start with depression, I'm going to show you a question, okay? Have a quick look at this. I'm just going to turn my camera off. Okay, so that's really interesting. Every single answer option was picked, okay? It just goes to show that it's an area that maybe some doctors are less familiar with, especially those who may be early on in ST1. But however, I'm happy to say that the two most popular answers were B and D. So PHQ-9 and hospital anxiety and depression scale, okay? B was the biggest one. D, actually not that many of you got, so less than a third of you got D. Now, the way that multiple best answers work in the AKT, you have to get them both right to get the 1 mark. If you only got one right and you got one wrong, you won't get half a mark for this, you'll just get nothing. So only less than a third of you would have got a mark for this, because you need to get both B and D to get the 1 mark. If you only get one out of a multiple best answer, you don't get any partial marks at all in AKT. So it's PHQ-9 and the hospital anxiety and depression scale are the two that are validated to do what? To assess the degree of severity in someone like this who, they're diabetic, they've got low mood, we've diagnosed them with depression. What would we use to actually diagnose the fact that they've got depression? Before we decide to do a screening tool to assess how severe it is, how are we going to actually make the diagnosis? What do we use? Feel free to type that in the chat. Let's see what people think. Yeah, absolutely. Great. It's called a history. It's a great fun. Try it sometime, right? You take a history of their symptoms, looking for the diagnostic criteria, either ICD-10 or DSM criteria to decide that they've got depression, okay? Things like the HADS, these are screening tools, and they're used for severity, but we have to make the decision clinically by taking a good history. Absolutely great. Okay, so now, if I just go through some of the other ones that are listed here. So there's 3 tools that are validated for use in primary care to screen for depression and to assess how severe is that depression. So they are PHQ-9, which has 9 questions about depression and mood. There's the hospital anxiety and depression scale. So one of the reasons a lot of doctors don't pick this one in the question we've just did, just done is the fact that the first word is hospital, but actually validated for use in GP. Now, HADS has got 14 questions. 7 of them are about depression. 7 of them are about anxiety, okay? And then the last one is the one that is least commonly used. It's the BDI2, the Beck Depression Inventory, 2nd edition. And the reason for that is 21 questions. Now, I appreciate those of you in ST2 or ST1, when you're doing GP, you've probably still got 20-minute appointments. Those of you in ST3, you're probably on 15 minutes by now. And when you get to the end of ST3, you might move to 10 minutes. Who's got time in 15 minutes to go through 21 questions? Do you see? And so that's why it's not used that often. Although one of the things that people would often do is they've made the diagnosis clinically. You might give someone, like I would normally give someone a PHQ-9 to take away, fill it out, drop it back, and then I've not used that to make the diagnosis. I've diagnosed based on history, but I'm going to use that then after they've been on treatment for a few months. I'm going to do it again to see, are they improving? If they're not improving, I might increase the dose of, say, the citalopram or the sertraline or fluoxetine that I might have started them on. Okay. Now, if we look at some of the others that were listed there, the Cornell scale for depression is a screening tool for depression, but it's specific to patients with dementia. And this patient didn't have dementia, they had diabetes, but dementia wasn't mentioned. So it's not suitable for this particular patient. The Edinburgh Postnatal Depression Scale, the EPDS, this is specific to the risk of postnatal depression. So you give this to ladies who are going to give birth soon to look at their risk, or sometimes you give it shortly after they've given birth to look at their risk of developing postnatal depression in the first year after giving birth. And then the other two that were mentioned there, the 6-CIT and MMSE, both of these are for assessing cognitive function, particularly useful in screening for dementia, for example. And then finally, one of the options was PHQ-2. Now, PHQ-2 is actually the first 2 questions from PHQ-9. It's a fantastic tool as a rapid screen for depression. So particularly useful, for example, if you are doing a CSA case and you've got someone who comes in with, maybe you've got a chronic disease review for, something else, rheumatoid, celiac, and there's lots of chronic illnesses where we should keep in the back of our mind, and if you're doing a chronic disease review in clinic, keep in the back of your mind that they might be at risk of low mood, because often if your symptoms are causing problems, it can start affecting your mood. But also, for example, if someone's a carer, we should also do a rapid screen for depression. And so PHQ-2 is great for that. And simply, this is the nice recommended screen in primary care. You just ask these 2 questions. In the last month, have you often been feeling down, depressed, or hopeless? That's the first question. And then in the last month, have you often been bothered by having little interest or pleasure in doing things? Anhedonia, okay? That's the second question. Now, if they answer yes to either one of these, there's a 95% specificity that they may have depression, okay? And so what you want to do is, you want to do a full history of low mood, a more detailed screen. Whereas if they say no to both of them, they probably haven't got low mood. Okay, it's very good to rule it out. All right. Whereas if they answer yes, not to both, if they answer yes to either one, it's enough there that you want to do a proper depression history and screen for depression in more detail. Okay. Right. What we're going to do now is we're going to look at a sort of CSA type case, but also the kind of thing that you might get in clinic to look at the next screening tool. Okay, so it was one of the things we mentioned was that you might look at screening for someone with dementia. You might use something like 6-CIT or MMSE. Now, MMSE, you need to have the sheet in front of you for the purpose of an exam like CSA. If you've got a patient and they come in and they seem a bit forgetful or something like that, actually it can be quite useful to do a quick screen like 6-CIT. Okay, so this is the kind of information you have when you're sitting in your room at the Royal College in London before the patient knocks on the door. You have 2 minutes to read. So you see this kind of information. So I'll give you a second to quickly have a look at that. Okay. Okay, so there we are. Now, how might this patient come in? They might come in and one of 2 things commonly in someone that comes in with forgetfulness. So one is they've noticed and it's starting bothering them. The other is sometimes the patient says, oh, my wife's told me I got to come and see you, or my daughter's worried about me and they've made me come in to see you. They've booked this appointment. I didn't really want to come. And you sort of tease out what's going on. And they might mention that there's some forgetfulness and things like that. So what we're going to do is let's look at the data gathering section. So this is usually the first half of the consultation. Let's skip past the introduction. I've come in, I've said hello, and I've said that, look, I've come under sufferance. My daughter said she's a bit worried that I might be forgetting things, okay? And what are some of the questions that you might want to ask me? And I'll be the patient, okay? I'll try to answer them. So if you want to ask a question, ask away in the chat, okay? And I'll try to answer them. So what might you ask this patient who says that his daughter's asked him to book the appointment and they're worried that he might be forgetting things? Just give you a second to catch up with me. There's a slight delay because of the number of people that have joined. Okay, so someone's asked a good question. When did it start? Well, I've not really noticed a problem, to be honest. It's more my daughter's asked me to come in. She says that she's noticed it over the last 6 months or so. Okay, so someone said, why does your daughter think so? Well, there was like a couple of times where, you know, she'd come to see me in my flat and we were chatting in the living room and then she could smell smoke. And you know what happened is I'd put the oven on and totally forgotten. That was one. One time I'd gone to the pharmacy, but when I got there, I didn't remember what I went to buy. And so anyway, I phoned her and I said, look, did you ask me to come here? And she said, no, I didn't ask you to come. You came for your own reasons. I didn't really know. Okay, so someone's asked, do you think I have this problem? Well, I don't really notice a problem myself. I don't think. I've really come under sufferance. You know, she's asked me to come. I'm humoring her. She's you know, my only daughter. I love her very dearly. I don't want to disappoint her. So, you know, someone's asked, do I live alone? Yes, I live alone, but my daughter visits me 2 or 3 times every week and I phone her most days. Okay. So someone's asked, can you understand why your daughter might be worried? Yeah, I mean, I can see things like with the cooker. Of course, had she not been there and mentioned it, I would have smelt it. But of course, you know, that is dangerous because if it happened when I've been asleep, I mean, that could have caused a problem, couldn't it? Okay. Okay, good. So let's look at how, if we wanted to be a bit more specific now, you've asked some of those things. You might ask someone said, you know, ask about some questions about safety. So things like, you know, have I ever locked myself out of the house? Have I ever forgotten where I'm driving to? You might ask about driving. Have I ever taken the wrong medication? If you go back to the information you had about the patient before they knocked on the door, you know, he's on amlodipine. So you might ask, am I missing my medication, or am I taking the double dose some days, for example? That could be dangerous, couldn't it? Things like that would be important, right? But how could we specifically screen within the consultation? Is there a level of cognitive impairment? Is there a level of risk of that this might be dementia, and you know, therefore we might need to do something? Well, one of the things that you could do is you could use 6CIT. Okay, so I'll go through the questions. All right. So 6CIT, you would say to the patient, look, if you could humor me, I'm going to ask you a couple of very specific questions that's going to help me look at whether or not your memory might be an issue, because you said that your daughter's been worried. So that's a nice way to broach it, if you like. And, you know, the patient will then humor you. So the first thing you ask is, what year is it? And if they're incorrect, so, you know, it's 2020. If they say 2019, 2021, it doesn't matter how far they're incorrect. It's just not the right year. That's 4 points. Next thing you do is, what month is it? Okay. If they get that wrong, it's 3 points. Then you say to them, right, I'm going to give you a name and an address. I want you to remember this. I'm going to ask you later. So you tell them it's got 5 components. Okay. John Smith, 42 High Street, Bedford. So first name John, second name Smith, the number 42, the road, High Street, the town, Bedford. Okay, it's got 5 components to it. So you tell them that, and you say, right, I'm going to ask you to tell me that at the end. And then you say, right, what time is it roughly? If they're within less than an hour, that's okay. If it's more than an hour, then that's considered incorrect. So, you know, like now it's 8:20. If they said 8 o'clock, it's okay. If they said 9 o'clock, it's okay. If they say 7 o'clock, that's more than an hour away. Do you see? That's incorrect. Okay. Then you ask them, okay, if you could just bear with me, could you start at the number 20 and count backwards until you get to the number 1? So they should go 20, 19, 18. Often they'll skip one, 20, 18, 19. Oh, sorry, 20, 19, 18, 16, 15. Do you see? Any one mistake, 2 points. More than one mistake, 4 points. Then you ask them to say, okay, let's do this again, but not with numbers. Could you start with December and say the months of the year backwards from there? So, December, November, October, September, and so on. So one mistake, 2 points. More than one mistake, 4 points. Exactly the same scoring as counting backwards. Then you say, right, could you go back and just tell me that address I said to you earlier? Okay. And any error is 2 points. So if they get all 5 bits wrong, they say Jason Llewellyn, 55 Borders Road, London. They got all 5 bits wrong. That's 10 points. And let's say they get most of it right, but they got 1 bit wrong, maybe the first name or the second name or the number. That's 2 points. So 2 points for each one. Essentially, anything more than 7 is significant. Now, you might be thinking that's quite complex to score. Just as a rule of thumb, if they get 3 or more areas where they're making mistakes, they're usually going to score more than 7. Okay, and then you're going to think, okay, this is a good likelihood that this could be dementia. I probably need to do something about it. So let's say now for this particular patient, let's say I've gone through it and I've scored 10. And then with the history that I've given a couple of examples of where I've forgotten, now you're probably thinking, okay, look, it looks like this patient has got dementia. Okay, what are you going to think you're going to do in terms of management? Okay, I'll put up some options here. I'll launch the poll again in a minute. So I'll just give you a second to have a look at that. So the most popular answer was D, refer to memory clinic. Okay, D, refer to memory clinic. Hardly anyone picked stopping the medication. I don't think anyone picked admitting to hospital. But D, had a few people picking refer to neurology. But the most popular answer by a huge margin was D, refer to memory clinic. If I go back to the patient once more, something really, really subtle and important. It's patient 62. Okay. So actually, memory clinic is not the right answer for this patient. The right answer is E, refer to neurology. Okay, so most people would have got that wrong. All right. Don't worry if you did. That's one of the reasons you're here, right? Is so we can cover the guideline. Why is that? Well, let's go through when we should do what in terms of management of suspected dementia. So if you've got someone who, because of the level of cognitive impairment, they're severely disturbed, and you think that they're a threat to the health and safety, either to themselves or others, you want to admit those patients. That's very, very few patients, okay? But that can happen. Someone who their level of dementia is so much that they're agitated, they're really distressed, they really don't know what's going on, they're very disorientated, and it might be dangerous for them, especially if they live on their own. You might need to admit those patients. Then when should you refer to a specialist psych or neuro service rather than a memory clinic? If they're high risk. So high risk are younger than 65 years of age. This patient was 62, very close to the threshold. If on examination, they've got focal neurological signs. If they have very rapid cognitive decline, i.e. it's in weeks that's changing, okay, rather than in 6 months to a year. If based on the history, and so that's why family history is important, you think that they're likely to have a genetic cause for their dementia, right? There's a strong family history of it. Or if they've got existing learning difficulties such that even a small level of cognitive impairment is going to significantly impact their sort of ability to get by. All of these need to be referred to a specialist neurology or psychiatry service, not to memory clinic. Everyone else, so you've got a patient who is in a low risk, they're over 65, it's a typical history where it's been months to years rather than weeks. All of those we refer to memory clinic. Okay, so that's a very difficult question, but I just wanted to clarify that that's the current guidelines from NICE. Okay, now how might we explain that to a patient? Okay. In terms of what does dementia mean? Well, that's one of those things that sometimes, if you haven't thought about it beforehand, how do you say it in a way without using lots of technical terms or jargon? So here's an example. You might say that dementia is a type of illness that it's associated with getting a worsening of the way that the brain works. And it can cause lots of different problems, like it can affect your memory, which you might have noticed or your daughter's noticed. It can also affect your thinking speed. So sometimes you just feel that you're not as sharp, that things are slowing down a little bit. Sometimes you can't find your words because it can affect your language. Sometimes it can affect how easily you understand things when people are explaining it to you. And it can also sometimes affect your mood. It can sort of get you down a little bit. It can affect physical things too. So sometimes it can cause problems with balance in some cases and movement. And as a result of that, it can cause problems with doing your daily activities when you combine changes in thinking speed, memory, and physical. Now, there's different types of dementia. A really common one you might have heard of is called Alzheimer's. So here's an example of how you might explain dementia. Okay, now the other one I want to touch on is falls risk, and then we're going to go into pain management, because I can see we've already spent half an hour on that topic. I plan to spend 20 minutes on that topic. So there's two really useful tests that I often find are useful, quick and easy to do in clinic. Okay, one is called the timed up and go test. The other one's called the turn 180 degrees test. So these are both for assessing risk of having falls. So let's say you had someone who presented and had one fall or something like that, and you're trying to decide, is this someone high risk that I probably need to get assessed in a falls clinic, or is this just like low risk and I can manage it myself in primary care? So I'll go through them. The timed up and go test, if I step back so that you can all see, hopefully you can all see me, I'll speak loudly so the mic still picks me up. Timed up and go test, you get them to get up from a chair without using their arms. So like my arms are going to be on my lap. If I go back, okay, I'll lift that up so you can see. All right, do you see I'm not going to use my arms on the chair to lift up. I'm going to keep my hands on my lap. Okay, I get up, I'll sort of crouch down so you can still see me. You get them to walk 3 meters. Your room should have at least 3 meters distance so you can do a Snellen test, right? Get them to turn around. Okay, so they walk there, they turn around, come back, sit down again without using their arms. If they use a walking aid, so if they use a Zimmer frame, if they use a walking stick, normally let them use that while they're doing this test. And then what you're watching when they're doing that is, do they sort of fall to one side? Do you have an antalgic gait? Do you have an unsteady gait? What's their stride length like? Do they seem unsteady? But you're also timing it. So you start your timer when you say go, and then they walk, you're watching, you're observing, then they come back, turn around, sit down. If they score sort of 12 to 14 seconds plus, that's a high risk of falls. Okay, certainly anything above 14 seconds is very high risk. Whereas like if you or I did it, you'd probably do it in 5-6 seconds because they're only going 3 meters and back. Okay, so that's called the timed up and go test, because you're timing, they get up, they go, they come back. The other one is even easier. It's called the turn 180 degrees test. So again, I'll show you. Imagine I'm standing, but I'm crouching. So you get them to stand up and face you, and then you ask them, can you turn around until you're facing the opposite direction? And then you count how many steps. So that if I do it now, I'm facing the other way. I did that in 2 steps. Most people will do it in 2 steps. If someone is unsteady, what you'll see is they sort of shuffle, and so it will take them more than 4 steps. So 5 or more, that's a high risk. All right, if they can do it in less, that's probably okay. Most of us will do it in 2, maybe 3, okay? But more than 4, so 5 is the magic number. 5 plus, that's high risk. So they're 2 useful tests, the turn 180 degrees test and then the get timed up and go test. Okay, I'm going to move on to the next topic now. So we looked at 3 different areas where we might use different screening and assessment tools. So we looked at a few different tools for depression. We looked at dementia, and we looked at falls. We're now going to look at pain management. Here we're going to look at 3 things. So we're going to look at how we assess pain when we're taking a history. Then we're going to look at the WHO pain ladder. And then we're going to look at cancer pain, because every AKT, and very commonly in CSA as well, you'll often have a patient with palliative care issues or who's got cancer, and you might need to manage their pain. But in every AKT, there's always at least a couple of questions to do with drug dosage calculation. So common one is converting from one opioid to another. Another one is pediatric dosage conversions. We'll look at pediatric dosage conversions in a later session, but today we're going to look at opioid conversion. So if we start with assessing pain, if you've got, in the context of someone who maybe has got an established history of cancer, and maybe you're seeing them on a home visit, or they're called up in out of hours, or they've come to see you because their pain is not well controlled, one of the things you want to look at is there an acute illness that might be worsening the pain? Because it could be progression of disease and it's just poorly controlled cancer-related pain. But sometimes, imagine someone's got cancer, their immune system's weakened as a result of that, either because of the illness itself or often because they're on chemo and things like that. So let's say now someone like that gets a septic arthritis. They're going to be in a lot of pain. Let's say they get a cellulitis. That's very, very painful. Do you see? You want to look at, is there an acute illness that might be worsening their pain? Imagine someone with bowel cancer. Why might they present with really severe abdominal pain, sudden onset, getting much, much worse very quickly? What kinds of things could cause that? Yeah, absolutely. They might have obstruction, right? Okay. And so, you've got to look at, is there an acute on top of the chronic problem that's causing that? Once you've ruled that out, you want to systematically assess the pain. Now, there's lots of different systems you use. The key thing is that you have a system that you're confident with, that you're used to using, and that you can then use that in a way that seems very natural. Okay. So before I was a GP, I worked for a long time in palliative care. Okay. In fact, my master's degree, my project was on cancer pain management. And one of the methods that we would use there is called the PQRST method. Okay. So it's a systematic approach to assessing and taking a history of pain. So, P is for provoking, i.e., what brought on the pain? Is there something that makes it worse? Is there things that might make it a bit better? The quality of the pain. So what does it actually feel like? How would they describe it in their own words? So, like for example, if someone's got a burning pain, you might be thinking about dyspepsia. If they've got a sort of like it's like electric shock running down or tingling, you might be thinking about a neuropathic problem. If they say it's really sharp, you might be thinking about something different to if it's a heavy or an achy pain. Okay. R is for radiating. So, does it go anywhere else? Does it stay in one place or does it go anywhere else? Where does it go? Okay. S is for severity. So get some kind of measure. On a scale of 0 to 10, how bad is the pain? 10 is the worst pain in your life. 0 is no pain whatsoever. How bad is this? And that's going to give you an idea of how well are you controlling it with the analgesia that you're giving them and how much maybe you need to adjust it. I'm going to move my camera a little bit so that you can see me better. And then T is for time. So for example, did it come on suddenly? Did it come on gradually? Does it come and go? Is it there constantly? Is it worse at certain times of day and night? If it comes and goes, how long does it last? Something that lasts minutes, very different to what your differential is, to something that lasts for hours. For example, if someone's got headache and it lasts half an hour, it's not migraine if it's an adult. In an adult, a migraine has to last at least 4 hours, and it can last up to 3 days. Okay, children can sometimes get short-lived migraines, an hour or two. All right, so it just gives you a system to ask all of the relevant questions so that you're not missing anything. And then other things you want to think about is how is the pain affecting things like their mood, their sleep, their activities of daily living. Someone with chronic pain, it's a really, really high risk factor for getting low mood. But also things like if they're being woken up from their sleep with their pain, that is a real red flag that makes you worry about something really serious going on or something, worrying underlying it. And then in terms of managing pain, so I'm hoping you're all familiar with the WHO pain ladder, okay? The slide that you can see here, these are taken from our clinical case cards, which you might have seen on the group. So like handy set of cards where we've summarized lots of different guidelines. But if I just go through it, so step 1 is mild pain. Someone presents to you with, say, pain, typically if you ask them to score it from 1 to 3, 4, is considered quite mild, okay? First line would just give them a non-opioid analgesic. So simple analgesia is another word for that. Paracetamol, ibuprofen, that kind of thing, okay? Step 2 is for moderate pain. So here you'd go into a weak opioid. So drugs in this class, codeine, dihydrocodeine, tramadol, all in this class, they're considered weak opioids. Step 3 is severe pain. It's pain that, and you go up by the step, right? So, you've tried your non-opioid or NSAID, you've tried a weak opioid. Step 3, often you see this in cancer pain or in pain that's not been controlled with the other 2 steps. This is where you go to strong opioids, so things like morphine, oxycodone, fentanyl. On step 2 and step 3, you can also have alongside it, keep them on the paracetamol or an NSAID, because often you might think if someone's got really severe pain because of cancer and you've got them on morphine, what's the point having them on paracetamol as well? Well, actually, research shows that it reduces the amount of opioid that they need. And so that can help by reducing the side effects, because once you get onto strong opioids, often, you've got increased risk of the side effects. So things like it can start affecting your breathing, it can cause dizziness, it can almost certainly going to cause constipation. So you want to prevent it. You want to start them on a laxative if they're on a strong opioid, or even on a weak opioid if they're on it long term. If I've got someone on codeine long term, I'll put them on a laxative, to prevent them getting constipated. And then adjuvants are things that you can give alongside any of these steps, but specific to a specific type of pain that these things might not resolve. So for example, if someone's got specifically neuropathic pain, then you want a neuropathic painkiller. So things like gabapentin is very good. A lot of people in real world usage often use amitriptyline. Amitriptyline is not licensed for neuropathic pain. It's okay. Amitriptyline has 2 licenses. One is sleep disorder. The other is depression, okay, as a second line or third line agent. So it's actually an unlicensed use. So for the purpose of the exam, if you have a choice between amitriptyline and gabapentin, gabapentin's better because it's specifically licensed for neuropathic pain. Now there is an exception to that. Type in the chat, if I had someone with trigeminal neuralgia, I wouldn't give them gabapentin as my first line, nor would I give them amitriptyline. What would I give that patient as a first line painkiller if they've got trigeminal neuralgia? Just type that into the chat. Just going to see what people are putting. Yeah, absolutely. So almost everyone's got that right. Fantastic. Carbamazepine. So yeah, specifically for trigeminal neuralgia, carbamazepine is first line agent. Okay, great. Okay, and then for example, bone type pain, so things like zoledronic acid or ibandronic acid, these things are very, very good for bone pain specifically, especially like patients with bone mets that haven't responded, because often first line you might already tried them on like an NSAID. That can help for some patients, but that's not often enough. So you might add to that something like zoledronic acid. Okay, great. So that's the pain ladder. Now I want to look at cancer pain management. So have a look at this question. I'm going to launch a poll in a minute for you. I'll tell you now, apart from F, every single answer has been picked, and actually they're fairly even. So it just highlights that it's a hard question, okay? And actually from examiners' reports, we know this is an area that people struggle with, cancer pain management, and that's one of the reasons I wanted to cover it today, okay? So key things to decide when you're looking at the calculation is, first of all, what is their total amount of oral morphine equivalent? Even if they're not on oral morphine is the universal opioid. You look at the oral morphine equivalent. So the first thing is to calculate what they're on at the moment. They're on 60 milligrams modified release twice daily of MST, oral morphine. So 60 times 2 is 120. But look at this. They've used another 10 to 20 extra oral morph the last few days, i.e. some days 10, some days 15, maybe some days 20. They're using extra oral morph because their base dose of 60 milligrams twice daily isn't enough to control their pain. That straight away rules out A and B, which a lot of you picked. Why? Because fentanyl is no good unless someone's pain is very stable. Unless you know their opioid requirements and the pain has been stable, usually for at least a week, okay, then you could use fentanyl. But in this case, if it's changing rapidly from one day to the next, fentanyl is no good. When you put a fentanyl patch on, it lasts 72 hours, 3 days. You can't fine tune it. Okay, so this is not a good indication to use fentanyl for this patient. So your choices are either the syringe driver or the oral morph, okay, as in oral morphine modified release, MST, okay. So all we're looking at is the amount really, all right. So 60 times 2 is 120, and then some days 10, some days 20. Are they needing somewhere between 130 and 140 to control their pain? So what you want is to find out what's equivalent to about 130, 140. You might even go up a little bit, maybe 150. What you're not going to do is suddenly double it, are you? If you look at option E, 90 twice daily is 180. Can you see that's like a lot more than they're on now? It's not gone up a little bit. It's a 50% increase. That's way too much. And then look at this one, 120 BD is 240. It's like more than double what they're taking at the moment. That could kill them. You go up that quickly, that fast, Can you see? That could significantly harm the patient. So you're left with C or D. Are you going to put them on a syringe driver? What's the dose? The correct answer is D. 40 milligrams would be about equivalent, okay? Given over 24 hours would be about equivalent to what they're on. Why? Because if we look at opioid conversion, 10 milligrams of oral morphine is equivalent to about 3 milligrams of diamorphine given subcutaneously. So the conversion is divide by 3.3. So i.e., if they're on 100, it would be exactly 30, okay? If they were on 130, that would be about 39. 140 is about 40 and a bit. So 40 milligrams is about right, isn't it? To look at what they've been needing to control their pain, all right? If you divide that by 3.33, you get around that number. And then the breakthrough dose, for the purpose of the exam, usually it will be set at 1/6 of the 24-hour dose. I.e., do you see let's say someone's on 120 milligrams daily of oral morphine, you might give them each dose might be 20 milligrams, okay, a sixth, all right? So for example, if they're on 40 milligrams of diamorphine, what's a sixth? About 6.5 milligrams as a bolus dose you could give on top, okay? In real world usage, so when I worked in palliative care, we'd often use somewhere between a 10th and a 6th. Okay, and I see this as well in general practice, but for the purpose of the exam, generally they'll set it at a 6th. Okay, now I mentioned that fentanyl is only suitable if someone's pain. So I'll give you some examples where you might use fentanyl. You've got someone with esophageal cancer. Over time, they're not able to swallow anymore, but their pain has been very well controlled when they could swallow on oral morphine. So you know what they need. They're not having a sudden change. Now you could convert them. And essentially, if you want to do a rough calculation, take the total amount of morphine orally that they're having daily, divide by 2, and find the lowest number that matches that, okay? I.e. the closest one, but rounding down in fentanyl. Look, morphine 30 divided by 2 is 15. The closest one lower than 15 is a 12, i.e. a 25 is too high. If they're on 60, half that is 30. So the lowest one, but lower than that, the closest one, but lower is 25, i.e. 50 is too high. So that gives you a rough conversion in terms of converting fentanyl, but only if the pain has been stable for at least a week. You wouldn't put someone on a fentanyl patch whose pain is changing very rapidly, as this patient was. It's unstable. You don't know their opioid requirements yet. And then if we look at the other type of opioids, weak and strong opioids, these are the conversion factors. So morphine 10 is the universal opioid, right? 10 milligrams of oral morphine, whether it's liquid or a tablet, doesn't matter, is equivalent to about 5 milligrams of morphine given by injection, whether that's IM or subcut, IV, doesn't matter. Oxycodone is about a third stronger than oral morphine. So 6.6 milligrams of oxycodone is the same as about 10 milligrams of oral morphine. Okay, so roughly someone on about 100 milligrams of oral morphine, about 60 milligrams of oxycodone is roughly about equivalent. Diamorphine, 3 milligrams is 10 milligrams of oral morphine. So as we said, if someone was 100 of oral morphine, 30 of diamorphine in a syringe drive over 24 hours would be ideal. And then codeine, dihydrocodeine, tramadol, the weak opioids, they're all easy. They're all exactly 10 times weaker than morphine, i.e. morphine 10 is the same as 100 of codeine and 100 of tramadol. So for example, someone on the top dose of tramadol, 400 milligrams, the equivalent, if you're going to convert them to morphine, is 40, okay? It's 10 times weaker. The top dose of codeine is 240. That's equivalent to 24 milligrams of oral morphine. Okay, so we've got about 12 minutes left. As I said, I wanted to just touch on what do each of these job titles mean. I'm not going to go into great depth because over the course of however many weeks we keep doing this, I will go into a lot more detail about each of these. But I just wanted to touch into these, okay? And like, for example, next time we'll look at salaried in a bit more detail. We'll look at the pros and cons, advantages or disadvantages. Those of you in ST3, you might be starting to think about jobs soon, post CCT, post August for some of you if you've sat your exams. It might be a bit later for those of you that haven't sat your exams, depending when the exams come back online. So, but essentially, what do they actually mean? I just want you to be clear about them. So a salaried GP is an employee. So you will have a fixed contract, work a fixed number of hours. Usually you'll have fixed days of the week that you're working. You'll have fixed roles and you'll get fixed pay. If the practice does really well one year, you won't get any extra pay. If they don't do well, you won't get any less pay. You are employed. So it's similar to taking a job as a consultant in a hospital where you're employed by the hospital, you have your fixed hours, and then you get fixed pay. Yes, there might be times where they ask you to do some additional shifts, some overtime. You get paid for that, just like you would in hospital. But so as a salaried GP, you're an employee of the practice. You don't own the practice. You focus on the clinical work. There will be admin related to your patients, related to sometimes getting involved in things like the quality and outcomes framework and paperwork to do with that. But you won't be involved in hiring other doctors, in hiring staff. You won't be involved in the business side of the practice. You don't own any share of the practice. You are an employee. You get fixed amount of pay for fixed amount of hours. Okay, so that's a salaried GP. Then you've got locum GP. So a locum GP, another word for it is a freelance GP. So you don't have a fixed place that you work at. You might work in different practices. Now, sometimes people will take a long-term locum. So you might do a maternity cover locum where you're in one practice for 6 months, 9 months, 12 months. And during that period, you might work there full-time, very similar to one of the salaried GPs. But what's more common is most locums will have various practices that they work at. And what you see is that, especially a lot of experienced locums, there's the 80-20 principle. So 80% of your work will be from 20% of practices. You'll have a group of regulars. There's like 2 or 3 practices where I've done the bulk of my locuming over the last 13 odd years since I became a qualified GP. It's just a handful of practices. But then there's some practices where I've only done 2 sessions ever in 10 years. Some where I've only ever been there once and never gone back. So in a locum, you work in different practices, and sometimes you work in out of hours, sometimes you might work in a walk-in center, sometimes you work in a regular GP practice. And here, you might be self-employed, you might work through your own limited company, you might work through an agency, and we'll look at the pros and cons of those when we do a session on locuming later. But essentially, as a locum, you don't have any fixed income. You only get paid when you're booked for sessions and after you've worked them. So there's no guaranteed income every month. A locum might have, like when it's summer holidays, lots of people want cover. If you're not going away, you'll get lots of work. But there might be other times where people don't need a locum because they're staffed. And so you might want to work full time, but you might only get 3 days of work. Okay. If you get sick as a locum, you won't get any sick pay. If you go on maternity, you're not going to get any occupational maternity pay. And you've got to cover your own expenses. If you go on a course, you won't get any study leave. You won't get any study budget. You've got to pay for everything yourself as a locum. But on the other side, often you're going to charge more per hour because of those things have to be accounted for. A partner is someone who owns part of the business. So they're responsible for all of the other staff. So that includes the clinical staff, but that also includes the admin staff and the nursing staff and the allied health professionals. So you're responsible not just for your own clinical workload. So I'm a partner in my own practice. I'm a partner with one other person. Okay, so my best friend from medical school days. We opened a practice 3.5 years ago, and so as well as seeing my patients and he has his clinical workload, we both have our different roles in managing the practice. For example, I deal with all of the IT. I designed the website. He's the safeguarding lead. He dealt with the CQC registration, Care Quality Commission, inspections, things like that. So we have different roles in terms of the management side of things. But for example, we also got to be responsible for the rent in the building, for things like paying for the internet, the equipment, making sure we've got clinical supplies, getting locum cover for when one of us is on holiday or when we need skills that we don't have. Okay, hiring and firing people. We're responsible for all of those things. So a partner has additional roles. Typically, a full-time partner will work 10 to 15 hours more than a full-time salaried GP. Okay. As a result, though, a partner's got greater responsibilities. Typically, an income for a partner is a lot more than for a salaried. However, because you're running a business, each GP practice is essentially a small business. You have contracts with the NHS, or there are some private practices. Okay, you have contracts, and if your practice doesn't do well, then it's possible as a partner to make no money some years. Some months you will have a lot less income, some months you'll have a lot more. There is that level of uncertainty. So it can be hugely rewarding, both financially and sort of professionally. Some people like to be in charge, like to be able to decide the direction of the practice, what services you want to offer. But it comes with a lot of additional workload, admin side, and so on. Okay. And finally, you've got a portfolio GP. So I mentioned I'm a portfolio GP. It's an increasingly popular thing I'm seeing. A portfolio GP is someone with multiple roles. So typically they'll have a clinical role as a core role. Then they might have additional clinical roles that they do some of the time. Then they might have non-clinical roles. So I'll go into portfolio GP in a lot more detail in one of the sessions, and I'll talk to you about my portfolio. But in brief, for example, my main clinical role, I'm a partner in a private practice. I also work as a locum in NHS practices. I'm one of the resident GPs in a secure unit for women with severe mental health illness. So most of them are sectioned. They have a psych team that looks after their mental health. Myself and my partner look after their physical health. That picture I showed you in clinic yesterday, that was at that unit. Okay. I also work in community detox. And then I've worked in various other roles on and off. So as a prison GP, I've done medicals for the Army, as a civilian medical practitioner for the Ministry of Defence. I've got different clinical roles, right? Then I've got my non-clinical roles. The main one of that is I'm the medical director of eMedica. So, I teach courses all the way from medical students all the way up to GP trainers. I teach MRCGP AKT preparation courses and webinars. I was teaching a webinar yesterday for those on our AKT Pass Guarantee program. I teach for CSA, I teach communication and consultation skills, the GP entrance exams, and so on. And then I have other educational roles and professional roles. So I'm an examiner and invigilator for the GMC. I write for the prescribing safety assessment. Then I've got some roles that are not medical at all. I'm a trustee for a charity, for example. Okay, people typically have a clinical role. Some other roles, some people, for example, will develop a special interest. I've got a friend who's a GP with special interest in sports and exercise medicine. One of his portfolio roles is the team doctor for the England under-18s football team. He goes around the world when they're playing tournaments. Another friend of mine is a yoga instructor. Teaches hot yoga when he's not being a GP. I've got a friend who sometimes teaches at some of our courses, who is a media GP. You'll see her on the BBC a lot, but she also is a GP with special interest in women's health. One of my friends, he's a GP with special interest in dermatology and in minor surgery, and then he's a salaried GP part-time. So it just means a GP with different roles, okay? And it's something that's increasingly popular. So that's just an overview at a very broad level of what some of these. You might have heard some of these words and not really had a clear understanding. What does it mean? As I said, in later sessions, we'll go through these in a lot more detail. Okay, good. So what I'm going to do is I'm going to spend 5-10 minutes going through questions now. But what I'm going to do is, while I start looking through the questions and give you a chance to write questions, as I mentioned, if you write a question in the chat, it won't be picked up because there's so many people on, I won't be able to pick it up. And if I don't get to your question, I'm going to try to get through as many as I can. If I don't get through them, feel free to email me or ask your question in the GP Training Support Facebook group. If you're not already in that group, there's 18,300 plus doctors in there, all either in training or applying. We've got a lot of trainers and examiners in there as well, actually. So what I found is if you ask a question, usually within 10-15 minutes, you'll get someone really helpful. It's a really friendly bunch of doctors in there that will answer your specific question. And, to a level of people who've been in that training scheme can give you advice about specific jobs. But just while I allow people to start asking those questions in the Q&A, please, not in the chat. I'm just going to do the summary because in case anybody hasn't got questions and you want to leave, I don't want you to feel rude. I don't want you to feel like you have to hang about. I'm just going to do the summary and then I'll take questions. So just before we go, if you haven't already joined the GP Training Support group, please do join the GP Training Support group. So I'll show you what that looks like now, and then I will send you the link for it in the post-course reading that will come out to you tomorrow. Okay, so it looks like this, GP Training Support. Okay, so you'll see it like that, and you'll see there's like 18,400 odd doctors there, all in training all over the UK, and there's also doctors applying. I will send you the video recording of this session, the 1 hour session, and the teaching slides that we went through by the end of the day tomorrow. So by 6 p.m. tomorrow, you should get it. And then if you found it helpful, please let me know in the chat, in the comments, or email me what you thought. It's the first time I'm running this particular type of session to this big a group. We've done lots of teaching sessions over the years just for members of the group. We open this up to anyone in any training scheme anywhere in the UK. And it looks like we've got some international doctors joined us as well. Next week's going to be a bit later. It's going to be 8:15 to 9:15, same format. We will do a couple of clinical topics, and then we're going to do careers topic at the end, okay, where we'll probably look at in a bit more detail about salaried GP. So, do let me know what you thought. And then just before we finish, I want to finish with this message from Rumi, who said, wear gratitude like a cloak and it will feed every corner of your life. Why am I bringing this up? Look, I know, like you, a lot of us have got additional pressures at work. And then if you see the figures and the stats and what's happening, on the front line, it's scary. A lot of us have got a lot of people that we know personally who have been unwell, who've been in self-isolation, colleagues, family members. Some of us have got family members who are in vulnerable groups, and we're worried about them, we're scared about them. At the same time, some of you have had your teaching cancelled, and so you're stressed. You don't know when your exams are going to be. If you're waiting to sit the April AKT, or you're about to sit CSA in March, you're not sure what's going to happen with your CCT. There's a lot of uncertainty. And I know it can be scary, I know it can be difficult, but one of the reasons why I encourage you to join the support group and why I'm running this kind of session is it's important to have some sense of normality, that we still look at what things we can find to be grateful. And I want you each to think about one thing that, despite all the pressures and all of the difficulties that we're all facing, that you're really grateful for. So like one of the things I'm really grateful for is that because schools close, having my kids at home, and because we're not running courses, we're still running courses and webinars via live stream like this, but I'm not traveling as much as I normally do. I'm getting to spend a lot more time with my family, and that's really, really precious to me. And then yesterday we were running an AKT webinar, and one of the doctors said that they were really grateful that we still have jobs. Some of our patients, I know they're in a kind of job where, if they work in a restaurant that doesn't do takeout, they've just shut their business. They've got no job, as well as dealing with all this stress. They've got financial issues. We're very blessed, I guess, that we don't have to worry about that we still got a job that is needed. And yes, there's dangers in there. And, I hope that we all get better PPE, for example, and that testing is more widely available as it's starting to drip through. But I think it's really important that we do count our blessings, because it will help us to deal with some of this stress, to deal with some of these issues that are going on. So I hope that's been helpful. Anyone that is going to leave now, thank you so much for joining. I really do hope you've found it helpful. If you have, please do feed it back. Do let me know, because then I'll keep running it. If people aren't finding it helpful, I won't keep running it, because my evenings are precious to me too. Okay, but thank you very much for joining. I hope it's been helpful. All the best. Stay safe out there. Thank you for all your hard work out there on the wards and in your practices. Okay.